MD News Network recently attended the Medical Group Management Association's annual conference in New Orleans, where our cameras focused on attendees with opinions on everything from healthcare reform to healthcare technology. Here's what they had to say.
They engage in many ways, depending on the age of the practice, the size of the practice. My practice being about 20 providers and also contracted the large health system, we're actively engaged with our health system in many ways, both directly in providing services and indirectly in doing clinical decision making and medical leadership across the entire health system spectrum. New Jersey's a very diffuse state in terms of healthcare though, and that is a real problem. It also has the issue of geography, being in between two of the major metropolitan markets and also the two major metropolitan healthcare centers in the United States. So competitively and clinically, it has a lot of challenges in delivering local healthcare at a high quality level. Though at the same time, it has the opportunity to bring technical skill out to the suburbs, which is unique.
Talk about your experience.
I basically run a small physician group, 9-physician, primary care. I'm right on the outside of New York City, which gives us a whole nother dilemma with quality staffing. We have a higher pay scale because we have to match New York City. So it becomes a very dynamic, different type of healthcare system. The other issue we have in our particular area is physician integration. Physicians, for some reason, very local, don't want to be in major groups. I'm one of the largest physician groups, 9, being large, is unheard of in most metropolitan areas. But trying to bring physicians together and work with each other has been very difficult over the few years. So.
Same experience as far as
well, New Jersey's a little. They've been networking large single specialty groups in the state, and that's been a trend mostly coming from the south and up to the northern part of New Jersey. But from an integrated delivery system, there's really only one private group in the state, and the others are academic medical centers. So there's never been a real history of having true clinics or in the sense of a Mayo or anything out west in terms of integrated delivery systems with the private community. So there's been significant challenges in a lot of ways to truly deliver high quality care in what's been measured even by the federal government.
Yeah, and there aren't that many integrated delivery systems in here. I mean, hospitals are now again starting that process, but they're not working. They don't have a system going yet. They're just doing it because they think they need to do it. Nothing in place to make it go forward yet. So I think it's going to be a long time before you see the kind of systems that you have out in the Midwest and the southern Philadelphia area that would be beneficial to all physicians.
It's really tough. Private practice and the reimbursement system and trying to fight the reimbursement system and a competitive marketplace is hard. Doctors have tried to do some networking and have some enhanced contracting arrangements, but I think really, and I can spell it, John and I have been colleagues for many years. John's taken a unique approach to try to keep his cost as low as possible and keep his ratios of employees down. And he's also been an early adopter of technology, which has helped him tremendously in doing that cost reduction.
Yeah, that's one of my advantages is I basically have very low staffing ratios. I use technology for everything. We've implemented EMR in 2000. We were early adopters, unheard of in our area, and most of the physicians in our area still do not have EMR. I mean, quite unheard of in this day and age, but I use technology. I also use technology for my employees. I make them more productive by giving them the tools that they need. There's a lot of cost involved, okay? I mean, I had the commitment of the physicians to go out and basically purchase the systems, get it all up and running. But even in those dollars back then, I negotiated some great deals, but when you talk about $15,000, $30,000, $40,000 per physician cost, the reimbursement doesn't give you enough of a markup to give you that incentive to go out and do it. They're still making the same amount of money if they did it on paper or if they did it electronically, and that's the problem. I mean, hopefully the incentives down the road will force physicians into, $44,000 a physician. That would help pay for that, and they might and they would adapt it at that point.
The next issues I am sure in our state we're going to be dealing with is the siloing of information that still exists. We are pretty far behind in the state in terms of regional health exchanges and how that's all going to work. It's finally starting to be developed. New York incentivized and did that through the state, and now New Jersey's finally tried to incentivize some of the regional players. And to be honest with you, the hospitals and the healthcare systems really have more capital availability than we would. So we really look to them to see what's going to happen in that marketplace. And the government definitely has to play a role in all that. So. It's a huge issue. Anything that, listen, doctors historically have not been capital reservers.
Right.
And the tax law doesn't help them at all with that regard. And they've optimized their revenue stream to do that. So not having that capital and then also not knowing where the future revenue stream is going to come from, they're businessmen. They want to have a good lifestyle. They want to have a good compensation. They want to, in their peer group, be able to be similar in their community, their social networks, their cultural networks as well, because a lot of them are looked as peer leaders in their school systems or their cultural activities or even just local theater. And it's hard because they want to still maintain that and also then maintain a quality of life and quality of practice and not have to keep on going every 5 minutes to get an extra $28 in reimbursement and worry next week that they're not going to be able to make payroll, it's a reality.
That's the main issue. It's the reimbursements aren't keeping up with it. So if you're looking at a 30% cut in Medicare, you're just going to drive the physicians back out. They're not going to go in and invest hundreds of thousands of dollars in equipment and software to make it easier for the government to collect data. There's no incentives, and that's part of the problem with the healthcare system. We're not incentivizing them to do it the right way. If reimbursements were on par, our marketplace, when people talk about Medicare rates, I mean, we get paid below Medicare rates probably 60 to 70% in our metropolitan market because of the uniqueness of 5 million people in that area. Just drives down the reimbursement rates, and they're not going to do it. They still need to maintain a quality of life, and what gets cut first is staff, and then after that is basically equipment expenditures, and after that, salaries on the physician side. For me, it's they need to solve the problem, simplify the system. Make it across the country, everything is equal. No disparity between, payers, between anything else. I'm a true believer of universal health care. Even though I don't think that'll ever get to that point, I think we need to do something. Healthcare is not going to change until we actually want it to change. That's how I feel.
And I'm a little bit different. I believe in like a hybrid system. I think the government should take a responsibility in preventative health care from birth to death. After that, I think you can have a tiered system depending on how people want to choose and what type of health care. So if people want to put in reserve and buy certain levels of extra health care, that would be great. And that would have to be decided what that really is. What is a baseline of health? Is immunizations and vaccinations and keeping weight down all part of the preventive health system? I remember the day, I'm not that old, that I got my polio vaccine at the school district. I did not get it at the local healthcare provider. So by that migration away, I think we need to go back and have more community-based models, and that's across the board. It could be community cost models, it could be community capitalization models. I think the healthcare system, they're going to have to team up in partnership. And there's a lot of different arenas, and because of technology, yes, we've been wonderful at developing the technology, but the application and the variability of that technology has been very bad for the system. There's been some people that have been very well served by that, and a lot of others who've just not been able to get access to it, and it's caused huge problems. The theory that we should have an employer-based subsidized system was great. I think it's kind of running its course. We're going to have to think of some alternatives, but those are for those who might be a little smarter than me.
Yeah. They have to get the patient back involved in the healthcare decision. That's the only way it's going to work. Because right now, people come in and to say, well, my employer pays for my insurance. I can have anything I want done. There's got to be a change to the system. I think somebody said it. I think Malcolm said it on Sunday night. Maybe we need to go back to the old system. Patient pays you, they deal with their insurance if they have coverage or whatever, and simplify the system.
In some ways they are, and of course in some ways, as any market, some people aren't hitting the mark at all. I think they're not looking to those who are the real partner in capital. A lot of them are not partnering with the managed care companies, and they really need to think about that. And they really need to think strongly about that, because in the end, that's who's going to really drive what capital investments are in information technology, and the government. So the government's made their stand. They've put out their grid, so to speak, and they're going to keep on doing it. And I think on the private side, the IT vendors are going to have to look to a lot of different partnerships to move forward.
I think they're on the right track. It's just that the interoperability, everybody's got their own little thing they're going, and the only way we're going to get to making everything work, like our speaker this morning said, basically, is to have one model, one platform, simplification, so everything works together. I mean, when I'm in my practice, I have 3 different systems that I use to make things work. So we need to simplify that. We need to make it streamlined, and we make it easier for everybody, for the providers, for the patients, and for the employers if they're paying for the insurance.
Now that you've heard what the MGMA conference attendees have to say, we want to know what you think. Click on Share Your Perspective at mdnews.com to let us know.